Are y'all in the same clinical quagmire that I am, trying to figure out what the best thing to do for patients in cardiac arrest with V-Fib is, that you just can't get out of V-Fib? Those refractory patients? Well, if so, stick around because I got a paper that may help us out here.
What is a lighthouse? It is a tower with a bright light at the top, located at an important or dangerous place. The main purpose of a lighthouse is to serve as a navigational aid and to warn of dangerous areas. Welcome to the EMS Lighthouse Project podcast, illuminating the darkness of current EMS clinical practice with the bright light of science. Here's your host, Dr. Jeff.Jarvis.
Howdy y'all, it's Dr. Jeff.Jarvis with another episode of the EMS Lighthouse Project podcast. I want to talk to y'all a little bit about refractory V-Fib. You know, in the last two episodes, we specifically talked about ECMO, and we talked about how ECMO for this patient population has mixed results, and it is almost always limited to big urban ivory tower institutions, which is not where most of us take care of our cardiac arrest patients. We've also talked extensively in other episodes about epinephrine and how, particularly in patients with shockable rhythms, there's probably not a lot of benefit, especially after that first dose. What else can we do for them? Well, we've talked about the limited evidence for amiodarone versus lidocaine versus placebo. And dual sequence defibrillation, while certainly promising results coming out of the pilot project for the dosed VF trial, we don't yet have conclusive evidence. So we're really left with the question, what do we do? So what about beta blockers? Well, beta blockers are something that's just standard of care for patients with post-MI care in the hospital. We give them beta blockers, typically oral, starting within the first 24 hours after admission, and we know that we're giving them those beta blockers as an antiarrhythmic. It decreases the likelihood of ventricular arrhythmias, and we think that's a good thing. So how about using maybe a short onset, short duration beta blocker in cardiac arrest to help as an antiarrhythmic to get patients out of V-Fib? Well, there have been a couple of trials, small artisanal data on Esmolol. Esmolol is the perfect drug for this. Very rapid onset, very short duration, great beta blocker, maybe that will work. And these early trials showed some promising evidence, but unfortunately they were so small they weren't conclusive. And there's certainly been nothing in the pre-hospital environment about this. So with that background in mind, the folks at the Montgomery County Hospital District EMS system implemented a new protocol for patients in refractory V-Fib that included a single bolus dose of Esmolol, and they dosed this at 0.5 milligrams per kilogram, and they did it after at least 3 shocks and some epinephrine and some amiodarone. Then they would give that bolus. Now, the citation for this paper, this was published in JCEP Open, Journal of the American College of Emergency Physicians, the open version, open access, and the title is Feasibility of Pre-Hospital Esmolol for Refractory Ventricular Fibrillation. The authors on this paper are some great folks down here. They're my friends, Dr. Casey Patrick. We've had him on the show before. Dr. Rimley Crow, we've had her on before. Brad Ward, Ali Muhammad, Kelly Keene, and Dr. Rob Dixon. Now, I mentioned MCHD EMS. That is suburban Houston, and it turns out to be where I am right now. I'm filming this from a hotel room in the Woodlands. We're down here to go see Jimmy Buffett. Hadn't seen Buffett in many years. Very excited about that. We're going to see him in the Woodlands. It's going to be a great show. So their primary outcome was feasibility. And what they wanted to know is, could they recognize V-Fib, refractory V-Fib, and give Esmolol in more than 75% of eligible patients? And then for secondary analysis, secondary outcomes, they wanted to report on the things all of us want to know. Did it get patients out of V-Fib and into a perfusing rhythm more, and did we have better survival? So let's get into the results, shall we? Figure 1 in this table is a great consort diagram. I'll run through it really quickly for you. Basically, there were 1,300 patients in the time period, about 3 years on either side of implementation of this protocol. They ended up with 87 patients in the before group that had refractory V-Fib and 105 in the after group. Now, on second analysis, several of those patients were not actually in refractory V-Fib. Turns out they excluded 24 in the before group, 33 in the after group. But once they got everything settled, also excluding traumatic arrest, they ended up with an analysis group of 63 patients refractory V-Fib before Esmolol was available and 70 after Esmolol was available. Now, overall, their primary outcome was, can we give this to patients that are eligible to get it? Well, they gave it in 61 out of those 70 patients. That's 87%, clearly higher than 75. Yes, it is feasible, no doubt about it. Well, let's talk ROSC, shall we? Because that's what we want to know. Basically, they found 38% of the patients in the Esmolol group had ROSC compared to 24% of patients in the control group. Now, that is clearly a trend. It's promising. But if you look at the p-value, it is not below 0.05, so not significant. It turns out when they looked at 24-hour survival and survival to hospital admission, survival to hospital discharge, no difference at all, identical numbers. Now, they did calculate an odds ratio, and what they wanted to look at is the odds of getting ROSC in the pre-hospital environment with Esmolol versus without, controlling for, all the usual suspects. And they found an adjusted odds ratio of 1.99, but unfortunately, the 95% confidence interval crossed 1, which means that this was not statistically significant. This was obviously a small study, but I think it was important for a couple of reasons. Number one, guys, props to you for the feasibility angle. I really like this. Clearly, you were going to go ahead and implement this protocol anyway because you were trying to find something to do for these patients. And I'll tell you, I'm in the same boat you are. I implemented it also for the same reasons. And I've been trying to find a way to report on these results. Feasibility did not occur to me. Strong work, y'all. So why is that so important? I don't think it is shocking. See what I did there? Refractory V-Fib, shocking. I'm kind of proud of that. It's not shocking that EMS could do it, but we proved it, and more importantly, we got this concept of Esmolol in pre-hospital refractory V-Fib in the literature. So the next group that goes to study this doesn't have to start from scratch. They can show that this is a plausible idea, and at a minimum, we're at equipoise. So I think this is important for that reason alone. Now, in terms of the outcome results, I really wouldn't put too much stock in what they found here. And it's nothing against them, it's just a small study. And we would anticipate that the potential benefit for Esmolol would be small. And if it's a small difference, it's going to need a larger sample size to prove significance. Decent trends here, but I think we need to see more data. The good news is that I think this helps us prove equipoise and helps us get ready to set up a larger trial, perhaps an RCT. What we know is that in the ALP study, where they compared amiodarone to lidocaine to placebo, no benefit. Maybe what we should do is redo that and add an arm in for Esmolol, or just swap it out and do Esmolol versus placebo. And let's see if that makes a difference. Let's go ahead and either include or not include dual sequence, depending on how the dose VF trial works, but move it up early and let's see how it works. I think the bottom line on this paper clearly shows this is feasible. It has some suggestion of benefits. We're at equipoise. This paper breaks important new ground because it gets the intervention of pre-hospital Esmolol on the table, and I think it really helps us move this needle forward. Great job. Thanks to Dr. Casey Patrick and his colleagues for this important work. Take care, y'all.
You've been listening to the EMS Lighthouse Project podcast, a proud member of the FlightBridge Ed podcast family and a Fire Dog production. Visit flightbridgeed.com for more information.